Hello, this is Mirrakhimov. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be talking about the renal and bladder point-of-care ultrasound or focus. I have no conflict of interest to report for this presentation. Our agenda for today includes an overview of kidney anatomy and function, indications for renal and bladder focus, etiology of post-renal acute kidney injury, how to obtain images, how to interpret images, and discuss some limitations and pitfalls of renal and bladder point-of-care ultrasound at the end. So let's talk about the kidney anatomy. It's a paired retroperitoneal organ surrounded by fibrous capsule, and it histologically consists of renal cortex and medulla. On this anatomical representation of a kidney, you see a more detailed delineation of kidney anatomy. You can see the renal cortex and renal medulla, which consists of pyramid, minor calyces, and major calyces. You can also see the kidney hilum consisting of vessels, such as renal artery and renal vein. On this pictorial, you see histological representation of a nephron, and also see which parts of nephron are part of renal cortex and which are part of renal medulla. Please take a moment to review this slide. Let's keep talking about the renal anatomy. As we discussed before, kidneys are a paired retroperitoneal organ. On the right part of the screen, you see a pictorial showing different anatomical parts of retroperitoneal space. Kidneys are oriented in an oblique fashion. That is very important for us to remember when we use ultrasound to scan renal system. Kidneys receive approximately 25% of cardiac output. It is interesting to mention that kidneys have a very low extraction ratio of oxygen. However, it is still susceptible to an ischemic insult, which is especially true for medulla. This is explained by the fact that medulla has a very high metabolic demand and also a little bit less developed vascular system compared to the cortex. Kidneys have numerous vital functions. To simplify, it regulates blood pressure, forms urine, which aids in acid base metabolism, removal of urea, electrolyte and fluid balance. It also exerts endocrine functions via production of erythropoietin, renin, and activation of vitamin D. Indications for renal and bladder point-of-care ultrasound include acute kidney injury, suspected nephrolithiasis, hematuria, and suspected infection in a high-risk patient, such as, for example, a patient who is immunocompromised or have diabetes mellitus. Etiology of obstructive nephropathy consists of nephrolithiasis or stones, prostate pathology such as benign prostatic hyperplasia or BPH, prostate cancer, neurogenic bladder such as, for example, patients with spinal cord injury, multiple sclerosis, diabetic neuropathy, and Parkinson's disease, malignancy such as bladder, renal, uterine, colon, and cervical, as well as use of certain medications such as opioids, anticholinergic medications, baclofen, cyclobenzaprine, and diazepam. So what about the performance of renal point-of-care ultrasound? It has sensitivity of about 70% and specificity of about 75% for kidney stones, sensitivity and specificity of approximately 80% for hydronephrosis, and sensitivity of approximately 82% and specificity of approximately 98% for renal cell carcinoma. So let's review some of the pro and con of kidney point-of-care ultrasound. In favor of it is it's a safe technique. It is readily available and can be done at bedside. usually little time to perform and train, and also relatively low cost. The downsides or shortcomings include limited visualization of ureters, poor performance in certain patient groups, such as obese patients and pregnant patients, and overall reduced sensitivity and specificity compared to CAT scan or computed tomography and magnetic resonance imaging or MRI. So let's talk about image acquisition. In adult patients, you can use either curvilinear probe or phase array probe. Each probe has potential advantages, such as, for example, easier placement between the rib spaces for phase array probe, high resolution for curvilinear probe. In addition to that, curvilinear probe can also image the whole kidney in a patient. Also, in a small adult population, such as patients weighing less than 30 kilograms, for example, and in children, the linear probe can be potentially used. So you can see the proper ultrasound probe orientation on the right part of the screen. For comprehensive point of care ultrasound, you have to use both longitudinal and transverse views. Right kidney is usually much easier to image because of a lever, which is an excellent acoustic window. Left kidney is not so much for several reasons. First of all, spleen is inferior acoustic window compared to the liver, and plus you have more interference from air, such as stomach air and intestinal air. Usually, you can still find it by placing the ultrasound probe in the posterior axillary line. Sometimes, in order to optimize the visualization of the left kidney, and if the patient is able to do so, you can consider a right decubitus position. So let's talk about how normal kidney ultrasound look. Kidneys usually have a hyperechoic capsule, which means brighter or wider. The kidney itself is usually relatively hypoechoic to the liver, which means relatively darker in color. And the renal sinus is usually hyperechoic because of high fat content. Here on the top right, you see a normal ultrasound image of the kidney. On this part, on the lower bottom right, you see a zoomed image into the renal medulla, showing you a hyperechoic structure. Again, please take a moment to review this slide. Let's discuss the grading of hydronephrosis by kidney ultrasound. For mild cases, it can be very, very subjective. On this pictorial, you see three different grades of hydronephrosis. Top left is mild, middle is moderate, and top right is severe. In mild cases of hydronephrosis, you typically see enlargement of the calyces and preserved medullary pyramids. In moderate cases of hydronephrosis, in addition to dilated calyces, you see some blunting of the medullary pyramids. And in severe cases of hydronephrosis, as shown on the top right, you see calyceal ballooning and grossly dilated renal pelvis. Please take a moment to review this slide. So kidney ultrasound has somewhat limited sensitivity for nephrolysizes. Why is that? For example, because it is very difficult to image whole ureter with kidney ultrasound. However, it can still be diagnostic, such as in this case, for example, where you have a kidney stone blocking the calyx of a kidney and encircled with green circle. And you also see the shadow from the kidney stone. On this right image, you see renal stone given dense shadowing artifact. Please take a moment to review this image. When performing kidney ultrasound, you must finish it by examining the bladder. For example, you can confirm appropriate Foley position. You can also estimate bladder volume. So how to estimate the bladder volume? You will need to image the bladder in the longitudinal and transverse orientation. So you multiply lengths by widths by height times 0.75, and you get your estimated bladder volume. Bladder volume should be less than 400 cc's, and post-void volume should be less than 100 cc's. Please take a moment to review this slide. Let's take a look and see how the Foley catheter may appear on bladder point-of-care ultrasound. Here on the right part of the screen, you see a picture showing you a Foley balloon and a full bladder. It can be either because the Foley catheter was recently placed and not enough time was given for the Foley to drain the catheter. But if it's an old Foley, one must consider a dysfunctional catheter, such as, for example, a clogged Foley catheter. And you may need to potentially flush it or even replace it. On this screen, you see another Foley catheter, but it looks like there's some obstruction of the Foley by some tissue, and it should also trigger either flushing the catheter or potentially replacing it. And on this slide, on the left part of the screen, you see a balloon and an emptied and decompressed bladder, which confirms the proper position and functioning of the Foley catheter. Please take a moment to review this slide. So what about incidental findings? Point-of-care ultrasound is by no means a comprehensive exam. So when you see something, it is important for us to defer given an exact diagnosis. You should follow up with a specialist consultation, which in most instances will be urology, which may decide whether additional imaging is needed, such as, for example, computed tomography or magnetic resonance imaging. Let's review how miscellaneous pathologists can appear on renal ultrasound. Here on the bottom left part of the screen, you see an image, kidney, and on top of kidney we see a complex mass which represents renal cell carcinoma. Again, on the superior pole of the kidney you see a complex mass. On this part of the screen you see a bladder ultrasound with a mass within the bladder, which is very suspicious for cancer or tumor. On this left part of the screen, top left, you see a kidney and a complex cystic structure suggestive of an abscess. And in this middle picture, you see a kidney with well-demarcated cystic lesion, which is suspicious for renal cyst. Please take a moment to review this slide. So what about some limitations and pitfalls? Renal cysts can complicate the diagnosis of hydronephrosis. Absence of hydronephrosis doesn't mean that there is no nephrolithiasis. Bladder mass and hematoma may appear similarly on point-of-care ultrasound. Like I mentioned before, POCUS has a limited scope. Always refer your patients with abnormal findings to a specialist and avoid giving specific diagnosis and defer the prognosis as well. Unfortunately, in certain patient groups, such as obese patients and pregnant patients, you may have suboptimal visualization of the kidney and the bladder. So in summary, renal and bladder point-of-care ultrasound is easy to learn and perform. It has good test performance for detection of hydronephrosis and distended bladder. If incidental finding is noted, refer such patients to a specialist and don't provide any specific information on prognosis and treatment options. I want to thank you for your attention. If you have any questions, please don't hesitate to email me to this address provided on this slide. I wish you all the best and good luck.